Welcome to This Explainer. Today, we're acting as medical detectives to unpack the really fascinating progression of cerebral abscesses. We're going to track down the microbial culprits, examine the physical evidence they leave behind, and map out the exact timeline of how these infections evolve inside the brain. So let's just dive right in.
Here's our roadmap for today. First, we'll identify the microbial culprits, and then see how those pathogens shift in special populations. After that, we'll review the clinical evidence in adults versus newborns, and finally, map out the histologic staging timeline.
All right, Section 1, the microbial culprits. Let's find the source of the problem.
Now, you might think we always catch the bug responsible, right? But surprisingly, up to 25% of cultures from cerebral abscesses come back entirely sterile. No bugs found. But when we do actually recover organisms, they vary heavily based on the primary source of the infection. Broadly speaking, Streptococcus is the most frequent offender, with about 33 to 50% of those being anaerobic or microaerophilic. Plus, we often find a whole gang of them. Multiple organisms are cultured in 10 to 30% of cases, and depending on the culturing technique, that can literally approach 60%. When it is polymicrobial, you're usually dealing with anaerobes, and bacteroid species are incredibly common here.
So what happens when we trace the infection back to specific primary sources like the sinuses or the lungs? Well, the specific suspects change. If a cerebral abscess is secondary to frontoethmoidal sinusitis, you're usually looking for Streptococcus milleri and Streptococcus aeruginosus. On the flip side, if the source is otitis media, mastoiditis, or a lung abscess, you're almost always dealing with multiple organisms. The typical isolates for these ear and lung sources include anaerobic strep, bacteroides, and Enterobacter like Proteus, for example.
What's really fascinating is how our suspect list dramatically shifts gears when trauma or surgery is involved. For post-traumatic cerebral abscesses, the primary invaders are usually Staphylococcus aureus or Enterobacteriaceae. Now, if the source is odontogenic, meaning it originally came from a dental infection, that uniquely points the finger at actinomyces. And finally, if this is following a neurosurgical procedure, you've got to be on high alert for Staphylococcus epidermidis and Staphylococcus aureus.
Moving on to Section 2, pathogens in special populations. Let's look at what happens when the immune system is vulnerable.
For immunocompromised hosts, like transplant recipients or patients with AIDS, the typical bacteria take a back seat, and fungal and opportunistic infections really step into the spotlight. We frequently see organisms that normally wouldn't cause an issue. We're talking Toxoplasma gondii, Nocardia asteroides, Candida albicans, and Listeria monocytogenes. We also see Mycobacterium and Aspergillus fumigatus, with the Aspergillus often stemming from a primary pulmonary infection.
Now we have to talk about infants, and understanding the exact mechanism of their vulnerability is absolutely crucial. In babies, gram-negative bacteria are incredibly common culprits. And why is that? It's because the IgM fraction of maternal antibodies literally cannot cross the placenta. That precise biological limitation is exactly what leaves newborns highly susceptible to gram-negative cerebral abscesses. Okay, Section 3, clinical evidence in adults. Let's explore how this actually presents. In adults, the clinical signs aren't actually specific to the abscess itself. Instead, they're mostly driven by the edema or swelling surrounding the lesion. Because of this, you're going to see classic signs of increased intracranial pressure, or ICP. Expect headaches, nausea, vomiting, and lethargy. Hemiparesis and seizures also pop up in about 30 to 50% of cases. But a key differentiator here is the timeline. These symptoms progress way more rapidly than what you would normally see with something like a brain tumor or neoplasm. Next up, Section 4, clinical evidence in newborns. Let's see how the pediatric picture completely changes things. So an infant's skull is entirely different because it has patent or open sutures, meaning the skull can literally expand. When you combine that expansion with a poor ability to fight off infection, this cranial enlargement actually hides those classic signs of pressure we just talked about in adults. Because the skull gives way, papilledema is remarkably rare before 2 years of age. Instead, you need to look for alternative clues, seizures, meningitis, and irritability. You'll also see secondary findings like a rapidly increasing occipitofrontal circumference, basically head size, and a failure to thrive.
And I really want to emphasize this next sobering clinical pearl. Most newborns who present with a cerebral abscess are completely afebrile, no fever at all. So the absence of a fever absolutely does not rule out an abscess in an infant. On top of that,
The overall prognosis for these newborns is, tragically, very poor.
Let's move into our final phase, Section 5, the timeline and histologic staging.
Before we break down the stages, let's set a baseline rule for this timeline. It takes at least 2 weeks for a cerebral abscess to progress through its recognized maturation process. And here's a critical pharmacological detail to keep in mind. Administering steroids actually tends to prolong this process, slowing the whole maturation timeline right down.
There are 4 well-recognized histologic stages here. We start with early cerebritis in the first few days, move to late cerebritis, then early capsule, and finally end up at a late capsule formation after 2 weeks. Let's dissect exactly what's happening at the cellular level and what the surgeon actually feels day by day.
In stage 1, early cerebritis, which spans days 1 through 3, the brain tissue is undergoing early infection and inflammation. At this point, the lesion is poorly demarcated. It just blends right into the surrounding brain tissue. Under a microscope, you'd see toxic changes in the neurons and perivascular infiltrates. Now, put yourself in the surgeon's shoes. If they were to insert an aspirating needle during this blurry, poorly demarcated stage, they would feel an intermediate resistance.
Moving right along to Stage 2, late cerebritis, covering days 4 through 9. The environment is shifting now. A reticular matrix begins to form, acting like a collagen precursor, and right smack in the middle, a necrotic center starts developing. Because the tissue in the center is actively breaking down, if a surgeon inserts a needle now, they'll feel absolutely no resistance. It's like hitting empty space.
During Stage 3, the early capsule phase between days 10 and 13, neovascularity emerges. Blood vessels are forming. You still have that distinct necrotic center, but now a reticular network surrounds it. A super vital clinical detail here is that this reticular network is less well developed along the side facing the ventricles. That makes it dangerously weaker on that side, increasing the risk of rupture. And once again, at this stage, the aspirating needle will meet 0 resistance.
We wrap up the timeline with Stage 4, the late capsule, which kicks in from day 14 onward. Now, a true collagen capsule has completely formed around that necrotic center, and you'll find gliosis right around the capsule itself. Because of this tough, mature collagen wall, the tactile feedback for a surgeon dramatically changes. They will feel firm resistance, followed by a very distinct pop upon finally entering the abscess with the needle.
I want to leave you with a fundamental, totally unique histological footprint of this pathology. A cerebral abscess is virtually the only process in the whole brain that leaves a collagen scar. Think about that. Almost all other destructive processes in the brain leave glial scars, but an abscess leaves collagen.
So, considering this totally unique collagen scarring process and that devastatingly poor prognosis we see in afebrile newborns, how might early detection interventions alter these irreversible histologic outcomes? The stakes here are incredibly high, and catching it early is absolutely everything. Thanks so much for exploring this medical mystery with me, and I'll catch you on the next explainer.